My name is Dr. Samir Jaber. I am anesthesiologist and intensivist. I work in University Hospital of Montpellier in France. I will speak about difficult intubation in intensive care unit patients. My talk will have three objectives. First of all, I will summarize some background about the situation of unplanned or planned difficult intubation or ventilation. The second is how to detect difficult intubation in critically ill patients. And at the end, I will try to give you some tricks to how to optimize difficult intubation procedure in intensive care unit. First of all, the first risk of intubation and or difficult ventilation is to lead to severe hypoxia and cerebral anoxia. This could lead at the final point to cardiac arrest and obviously death. This is not a simple procedure in ICU and is very associated to worse outcome. So if you should retain only one key message of my presentation, please, is in case of difficult intubation, please, your priority over everything else will be oxygenation. You should oxygenate the patient, please. And then at the same time, secondly, call for help. This is the major message of my presentation. So, it's difficult to evaluate clearly the difference between anesthesia care and difficult intubation and ICU because there are several different factors. As you know, in the operating room, you have a planned intubation in a very simple patients, not hemodynamically unstable patients, and it's always performed by skilled persons like anesthesiologists or anesthetic nurse. And then, however, in critical care, the patients are very more severe and the conditions are very difficult. And moreover, we need to intubate trachea in a very emergency condition. The range from anesthesia operating room is around 3 to 5% of difficult intubation rate, in contrary to ICU when the range is around 10 to 20%, depending of the admission types of this ICU. So, is difficult intubation in ICU associated to more complication? The answer is yes. In this study that we performed in anesthesia care in operating room and in intensive care, we aim to compare difficult intubation to non-difficult intubation in overall patients and in obese and non-obese patients and in ICU and in operating room. The main message of the study, if you are an obese patient intubated in ICU, you have more than 50% to have severe complication. In contrast, when you are not non-obese patient and you are intubated in operating room, you are less than 2%. This is a major message, and the risk of complication in this study were reported is difficult intubation, obesity, and critical care ICU patient. This means obviously, but it has never been reported before. So, in another observational study, we reported that around half of the intubation performed in intensive care unit in severe patients are associated with a complication, at least one overall complication. And half of this half, around 25% to 40%, are associated to severe life-threatening complications such as severe hypoxemia, severe collapse, cardiac arrest, and or death, and the other non-severe complication. We have the hypotension. We know today that the hypotension post-intubation, also called reventilation collapses, occurred around 1/3 of the patients. So you will absolutely try to prevent this hemodynamic complication at the same than the airway management. In this recent study that we performed, we evaluated the cardiac arrest and mortality related to intubation process performed in intensive care unit. As you see, we have, you see here the intubation associated to cardiac arrest occurred in 2.7%. It's very high, 1,000 more than in anesthesia care. So when you compare the patient who experienced an intubation-related cardiac arrest in comparison to non-intubation-related cardiac arrest, you have a double twice mortality. You see here 73% versus 30%. That means it's very surrogate of a worse outcome to have an intubation-related cardiac arrest. Second, how to detect difficult intubation a priori in ICU patients. The more simple, the oldest one is to use the Mal-Empathy score, as you see with 4 classes. Class 1, you see everything. You can see the soft palate, the uvula, the glottis. In contrast to class 4, the maximum, you see quasi nothing. Can we better identify patient at risk of difficult intubation in ICU using some data coming from anesthesia literature in operating room? Then we have very few data about ICU, but now we have more and more. We then performed this study when we developed and validated a score dedicated to ICU patients for difficult intubation called Makocha score from 0 to 12 points. This Makocha score is Makocha for Mal-Empathy score, Mal-Empathy score 3 or 4, counted for 5 points. The 5 points on the 12 of all, you see, it's the majority. The second one is obstructive apnea syndrome, obstructive apnea syndrome for 2 points. The reduced mobility of cervical spine, the limited mouth opening less than 3 centimeters, and you have some factors related to the pathology, then the coma or the severe hypoxemia. This is very important to have when you will intubate a patient in coma or with severe hypoxemia. It's more severe than non-severe hypoxemia or coma. And the last part is the factor related to non-operator. When it's a non-anesthesiologist, non-training, it's gone for 1 point. So the score from 0 to 12 could be associated to a percentage of difficult intubation here. In y-axis, you see you have low risk where you are less than 3, 4 to 7, you are intermediate risk, and above 8, you have a high risk. So how to optimize difficult intubation procedure in ICU? This can be summarized in 5 points to improve intubation procedure. Then first, a good preparation for the patient, the material. The second is to optimize pre-oxygenation. This is very important things. The third is to prevent collapse using early fluid loading and vasopressor, mainly noradrenaline. The fourth is to use probably the paralytic drug, the murolaxant, and perform a rapid sequence induction using a Selig maneuver. And the last is to check after endotracheal intubation when you put the tube in the trachea to be sure that it is in the trachea and not in the esophageal, to use a capnograph waveform to be sure that you have a CO2 expiration in case when you are in the trachea or in case you are not in trachea, you have no CO2 curve. So improving pre-oxygenation could be summarized on this slide. If non-hypoxemic patient, you can use only the oxygen balloon standard. If you have mild to moderate, you could consider high flow oxygen therapy. And in case of severe to mild or moderate, also you can use non-invasive positive pressure ventilation using FiO2 at 1%, and Optiniv, which is association of high flow oxygen therapy and non-invasive ventilation. We developed the recommendation for intubation procedure in Montpellier called the Montpellier protocol, using 3 parts: the pre-intubation to perform the fluid loading, vasopressive drug very early in case of diastolic arterial pressure less than 30, pro-oxygenate, prepare long-term sedation, try to be 2 operators, pre-intubation with RSI, and the post-intubation, as you see here, very fit to tube placement with capnography. Performing this bundle before after perform this bundle in this multicentric study, we can decrease the significant reduction of severe life complication from 32 to 17% that by 12. So we can use in difficult intubation, you can see here the stylet. This is very important. The video laryngoscope, the Cook-Heschman, can use the fast track LMA, the fibroscope, and the cricotomy. This slide summarizes the main tricks that you can use in case of difficult intubation. So you can also try to have a manual manipulation of larynx, called here optimal external laryngeal manipulation. Can use the elevation of epiglottis using the stylet, as you see here, to better guides the tube in the glottis. Can use all the extra or supraglottic airway devices you can see here, and mainly the laryngeal mask airway you can see with a success rate very close to 100%. Please, one point is to keep the waist joint fixed on only the elbow joint, as you can see in this slide in our unit. You see here. And then we have now intubation guidelines coming from different countries. So the take-home message in my conclusion is try to convince you that intubation performed in ICU patient is specific approach. It should absolutely be evaluate difficult intubation criteria. You should have an internal protocol using the algorithm and try to homogeneize the practice. You should improve pre-oxygenation by positive pressure, CPAP or non-invasive ventilation, systematic capnography, applied RSI. The formation training is one of the major points. And my last slide, please, algorithms should make the distinction between the primary outcome and objective is oxygenation to the secondary, which is tracheal intubation. Thank you very much for your attention.